without further ado, I want to introduce Dr. Cook to you all. Dr. Cook is a physician in Southern Indiana who specializes in family medicine, addiction medicine, and HIV medicine, but he's also the author of a book called Canary in the Coal Mine. This is how I was introduced with him, to him. I actually listened to it on Spotify, and it really outlines his journey as a physician who was treating the HIV outbreak in 2015-ish that stemmed from the opioid epidemic. So he's got a lot of experience in this area, and we're just very excited and thankful for his presence here today. So without further ado, Dr. Cook.
All right, thank you so much for that kind introduction. I've been practicing in Indiana for about 20 years, and I've done just about everything you can do in medicine. Done rural medicine, so it's kind of a very underserved area where there's not a lot of resources. So over the years, I've obviously done primary care. I've also worked in the emergency department, delivered babies, did C-sections, colonoscopies, EGDs, did tubal ligations, and just about anything you can think of, I've done. But in 2015, as Abby mentioned, the area where I practice, we were the epicenter of the worst HIV outbreak in U.S. history related to injection drugs. So I suddenly found myself in the middle of a lot of need, and needed to really respond to the needs of my community by learning a lot and pulling resources together. And over the next few years from there, I did become board certified in addiction medicine, in addition to my family medicine board certification. And moving forward 10 years, I've learned a lot. And I hope to share some of what I've learned with you today, because as you all are very aware, addiction affects all of our communities. And I hope to be able to equip you all to respond to the needs of your community in a way that is, compassionate. We can be faith-centered and compassionate at the same time, contrary to what social media looks like sometimes. And I hope that we can have a pretty good discussion around some of these topics as well. See if I can advance these slides or not. Oh, wait a minute, I haven't shared my screen yet, that's why. All right, can you all see that?
Yep, we can see it.
Great. There we go. So the workshop, as I mentioned, is designed to equip you all with the resources that you need to be able to respond to the needs of your community, to reduce stigma, to address systemic issues, bias, and respond in a compassionate way. One of the first things we need to do is to define what addiction is. And ASAM is the American Society of Addiction Medicine. They really are the standard for addiction medicine. And so if you ever want to learn more or get resources, you can always go to ASAM. But they define addiction as a treatable, that's important, it's treatable chronic medical disease affecting the brain circuits, genetics, and environment. Now, this is important. This definition is important because it does define it as a chronic medical disease. And that's important because it puts it in the same class as other chronic diseases like diabetes or congestive heart failure. And when we're looking at helping people with, let's say, congestive heart failure, for example, we know that somebody with congestive heart failure, they're going to experience this condition for the rest of their life. And so we need to surround that person with all the care that they need. diabetes. They need a nutritionist. They need a physician. They need a life coach. They need social support to help them maintain their lifestyle. But they're going to go through periods of instability, and sometimes that instability gets to the point where they need to be hospitalized. And so we will admit patients with chronic diseases to the hospital. That admission isn't treatment, it's stabilization. So as we're thinking about addiction and our people that we're working with, they need to be hospitalized. They go to an inpatient recovery program. We often call it treatment programs. They're really not going there to get their addiction treated and that's it. They're going to these programs to get stabilized so that they can come back to our community to continue with their treatment, similar to a condition like diabetes. Um, it does disrupt the brain, and we're going to talk about that a little bit more. But it really hijacks the brain, and there's true cellular growth that occurs, and that's why we talk about the circuits, brain circuits. Those are cellular growth, and similar to a reflex. You think about having your knee tapped and your leg kicks involuntarily, right? These circuits develop based on our environment, and we talk about people, places, and things. You hear that oftentimes in recovery circles. Those people, places, and things become associated with substance use. So that if you're in an environment with certain people, places, and things that you're used to using, it becomes this circuit, almost a reflex, to where we talk about choice a lot. In a situation like that, we kind of lose our choice and we end up, you know, behaving in a way that we wouldn't normally, not around those people, places, and things. So those circuits are really important. That cellular growth is really important. And again, why a 28-day program isn't going to treat someone. We're talking about the need to regrow circuits. So that's going to take 6 months, a year, 2 years, 3 years. Addiction is characterized by cravings, impaired control, as we were talking about, and then dysfunction, responding to stress in our lives. And we see this manifest through behaviors that the person doesn't like, and we don't like. There's sometimes employment issues where they lose their job. Sometimes they're not able to take care of their family, their children, their homes. Sometimes there's criminal behavior. And so what we want to do is separate those behaviors and addiction from that person's life and reestablish wellness in that person's life. And we can talk about ways to be able to do that. And we really want to focus, the entire talk on addiction not being a moral failing. These aren't bad people that need to be judged. These are sick people that need help. Substance use disorder, well, when we're talking about a chronic disease, there's certain important characteristics about that. There's an inability to consistently abstain. They may have success for weeks, months, but there's usually a relapse in there and continued use without intervention, without branching over to a new way of living, surrounded by new people, places, and things, new connections, new purpose and meaning in their life. There's impaired behavior control. There's what we look at in medicine is the cravings that people have for substances and ways that we can decrease those cravings. Willpower only goes a certain distance. Most people don't really like that they're addicted to a substance, and they do try to stop. But these cravings and withdrawal symptoms become very, very powerful. And at some point, that willpower does get used up, and people do return to the substance again. and again, there's a dysfunction in the emotional response. So sometimes people are diagnosed with ADHD, for example, and it's not really ADHD. It's that their brain circuits have been hijacked. Again, it's important to really focus on this this substance use disorder as a chronic disease because it does remove that moral judgment. It reduces stigma and it encourages the people that we're talking with and interfacing with to focus on the treatment of this chronic disease. It aligns real true medical science. There's decades of research here that we can apply to someone's life if we don't view it as a moral failing and we do view it as a chronic disease. We can harness this medical knowledge to actually help someone instead of just telling them to be stronger, do better. We can provide them the treatment that they need. It encourages compassionate approach to those individuals, and then it encourages a long-term recovery model. Because with any chronic disease, you do have relapses. The diabetic becomes unstable, the congestive heart failure person becomes unstable, and they do need enhanced treatment during that period of time, not less treatment. We talk about somebody with addiction experiencing a relapse. Some people want to pull away from that person and offer them less help because they need to feel consequences. We don't do that for a diabetic or somebody with congestive heart failure. We provide them more care, not less. So during these periods of relapse, of instability in a chronic disease model, someone with substance use disorder, they need more help, more care when they're experiencing these relapses. So substance use disorder, again, a chronic relapsing medical condition that is treatable. When we look at the brain, we know that there's certain areas of the brain that are dramatically affected by trauma, by adverse childhood experiences, and we're going to talk about those more next week. But the brain is literally changed in these moments. And you can see that here on this functional MRI. There's three main areas that are affected. There's the hippocampus, which is the memory center. It shrinks, and it makes it harder for somebody to remember experiences and learn from those experiences. Adverse consequences don't result in behavior change as strongly as they would otherwise. So just providing people with consequences isn't really going to change things because of this hippocampus issue with their memory centers being affected. They have a hard time distinguishing past and present memories, and so that that results in like a post-traumatic stress disorder sort of presentation because their past is pulled into the present and they have a hard time distinguishing that. Another area that is affected is the amygdala, and that's the area where the brain regulates emotional responses to stress. This area actually increases, it grows, so that when somebody experiences stress or just things in their life that's harmful to their emotions, they actually have an exaggerated emotional response to that. And we see this, with people that we work with. Something happens and it's just boom, they're off to the races. Some people will say they're bipolar. It's not bipolar. It's their amygdala is enlarged and they're having an exaggerated emotional response to normal stressors. We can get them into treatment. These brain circuits can heal, and that exaggerated emotional response can actually come back down to a normal level. Things like dialectical behavior therapy, which again we'll talk about more in the coming weeks, is really good at helping the brain heal from this sort of damage. The third area of the brain that's affected is the prefrontal cortex, and that's our rational, sound judgment, decision-making center. And so people have a harder time doing things like delaying gratification. Wanting to be satisfied right now becomes more important than maybe delaying that gratification to advance in their, their life. It's harder for them to make sound, rational choices. But again, neuroplasticity exists in the brain, which means that the brain can heal. The cells in the brain can grow new circuits, but it requires the brain to not be inundated with a substance that's overpowering the neurotransmitters in the brain, and that they're in a stable social situation that's supportive and they feel safe. Um, Everyone's basic human needs um, is required to be met in order for somebody to feel safe and to experience wellness. And we'll again talk more about that with like Maslow's hierarchy of needs, for example. But when that doesn't exist, the brain chemistry gets out of whack. But when those things are in place and people do feel safe and their needs are met, then the brain is allowed to heal. Um, so when we understand addiction as a chronic disease, again, we are encouraging a long-term treatment model. We're not just looking at somebody not using drugs anymore. We're actually looking at that person's entire life. And the substance that they're using is only a piece of that puzzle. And so to build a full treatment model, long-term treatment model, we really need to look at what that individual needs to have wellness in their life. And then we're starting to look at, building social networks of people that are going to be there for them no matter what. We're going to embrace the medical model and get them access to medication assisted treatment or behavioral health medications or therapy so that they can, again, start striving towards wellness and allow the brain to heal. So, what are the root causes of addiction to begin with? Why do people turn to substances? Sometimes there's experimentation. A lot of people experiment with substances, but they don't go on to addiction. They don't go on to substance use disorder. So, why do some people get to experiment and get away with it and move on with life and not, continue to drink or use opioids or methamphetamines, whatever it might be, and why do other people end up not being able to get away from this? There's a whole host of things. Genetics plays a piece of the puzzle, of course. But what we really know from medical science is trauma from adverse childhood experiences predisposes the brain and the body to substances. When your basic needs aren't met, your dopamine isn't released as a reward in the brain. But when you use substances later, it is. And so then all of a sudden the brain is associating that substance with your basic human needs being met. And so people return to the place where they feel like their basic human needs are being met, even though that's not true. The brain's been hijacked. Poverty, economic instability, lack of education, job opportunities, housing instability, food insecurity, social isolation, lack of social support, and even exposure to a toxic environment. All of these things can drive someone towards substances as a means of coping and allowing their brain to feel okay in the middle of a situation where really it shouldn't feel okay. It shouldn't feel okay to not be safe, to not be housed, to not have food. But what do you do when those things are occurring and your brain is hurting? You turn to a substance to cope. So, from a medical model, what do we do to help soothe that craving that the patient is experiencing? Well, there are three main medication-assisted treatments for opioid use disorder that we use in medicine. And I'm sure you've probably heard uh, of them, or at least some of them. The first one's methadone. Methadone is a full agonist. An agonist means that it stimulates the receptor. So it's stimulating the receptor just like heroin or fentanyl or an opioid would. It's just not supposed to be associated with a high. It's a very long acting medication that you really don't get that immediate high from, but it does kind of soothe things, decreases withdrawal, and decreases cravings, allowing someone to then start working with recovery support, therapists, et cetera, to be able to move past their addiction. The methadone is only able to be prescribed through outpatient treatment programs, federally certified. So just a physician practicing in a community cannot start prescribing methadone to their patients. People have to go to these opioid treatment centers. However, buprenorphine, which is typically prescribed as Suboxone, that can be prescribed by any physician. We were in a situation where you had to have a waiver in order to do that, which was additional training and certification through the DEA. But the government got rid of that because we're in the middle of such a crisis, so that any physician can prescribe Suboxone now. So there's no barriers to any provider prescribing Suboxone, or buprenorphine. Buprenorphine is a partial agonist. It only partially stimulates the opioid receptor. And again, it does reduce cravings and withdrawal. It can be done in an outpatient setting where a patient is able to participate more in community services. And the last one's naltrexone, and it blocks the opioid receptor. So you really cannot give this medication to someone who is in the middle of their substance use. They have to have a cleansing period of about 2 weeks before you can administer this. If you give this to them sooner, it's going to throw them into what's called precipitated withdrawal, which is a very uncomfortable state to be in. So typically somebody would go to an inpatient program, go through a withdrawal period. Usually medicines are involved to help them feel more comfortable from their withdrawals. And then this medication is started. Naltrexone can be administered as a monthly injection. So they don't even have to take anything. They just come into the office once a month and receive this injection. And it does, again, decrease cravings. Here's a diagram that kind of shows this in a more visual way. On the left, you see methadone. It fully embraces that opioid receptor, fully stimulates it. The middle is the buprenorphine, partially stimulating the opioid receptor. And then the one on the right, the naltrexone, where it's actually blocking the opioid receptor.
And Dr. Cook, there is a question in the chat from Dr. Curry. How do you handle methadone and pain management?
Yeah, pain. Methadone is an appropriate treatment for pain. And so any physician can prescribe methadone for pain. It's only when it's being prescribed for substance use disorder that it's restricted to the opioid treatment centers. But yeah, if it's for pain, any physician can prescribe methadone. Does that answer that question? Good. So dispelling some of the myths about medication-assisted treatment, probably the most important one that I really want to hit hard is this is not substituting one drug for another. This is actually treating a brain disease. If it was just substituting one drug for another, none of the behaviors would change in that person's life. But what we see when somebody engages with medication-assisted treatment is the behaviors change. You have less overdoses, fewer emergency department visits, fewer acts of crime in that person's life. Typically, somebody will be able to start functioning in their life at a higher level, start re-engaging with their family, employment. They get their sense of purpose and meaning back. And you see somebody going from who it might be on the streets, have lost their children, are unemployed. They may go from that state to being fully employed with a home, having their children back, doing well. And that's what we want for anyone. So by providing them medication assisted treatment, it allows them to regain their life, regain connection with their family, their purpose and meaning. So this is not substituting one drug for another. This is actually stabilizing a chronic medical condition and allowing those behaviors to go away, allowing that person to advance in life. Somebody on medication assisted treatment, they're not less committed to recovery. The commitment to recovery is not using the substance by seeking, advancement in life. A lot of people on medication assisted treatment, they're part of the recovery community that's going back into the community and working with people. They're very committed to recovery and in their own lives and in the lives of others around them. Medication assisted treatment is just that. It's a treatment for a chronic disease. We wouldn't tell somebody that has diabetes that they're less committed to controlling their diabetes just because they're on a medication. That doesn't make any sense. That comes from the stigmatization of substance use disorder. We need to remove that in our thinking, in our talking, and when we're communicating with other people. This is nothing more than a chronic disease, just like diabetes. And so treating it with a medication is appropriate. And these people are committed to their recovery. Even the recovery community will sometimes, tell people that they're not truly abstinent because they're on a medication. That hurts. That hurts me when I hear that, because the people in recovery should be about supporting each other. But I even hear that in the recovery community sometimes. But they're not using heroin. They're not using methamphetamine. That's the important piece of this. And they've regained their life and they're able to function in their life. That's what we should, want for everyone. And if a medication provides that, then who cares? Again, having somebody on medication for substance use disorder, it decreases their risk of death, reduces their risk of contracting a disease like infectious endocarditis, hepatitis C, HIV. People who's on buprenorphine or methadone, they're less likely to return to the emergency department. They're less likely to die. People who go through an abstinence only program where they're not put on a form of medication assisted treatment, they're actually at greater risk of dying within the first 2 weeks of completing that program. And I would say, any program that increases someone's risk of death has to be questioned.
Dr.
Our goal.
Oh,
sorry.
go ahead.
What were you going to ask?
Another question: how long do they stay on the medication generally?
Yeah, it varies. How long does someone stay on a blood pressure medicine or for insulin? It varies. Some people with diabetes and high blood pressure, they go through a period of lifestyle change. Maybe they lose some weight, start an exercise program, reduce the salt in their diet, etc. And they're able to come off the medication because their lifestyle is supporting their health to the point where they don't need the medication. Sometimes all that behavior change, all that lifestyle modification isn't enough. And they are still experiencing elevated blood sugars, elevated blood pressures. Their heart failure is still causing problems in their life, and they have to stay on that medication longer, sometimes their entire life. The same thing with substance use disorder. Some people, it might be a month or two. Other people, it might be a year. Others, it might be multiple years. And, some people may never be able to come off that medication. Um, it's not the length of time, it's the behaviors that are going on in the person's life and the cravings that they're experiencing. So if they're on a medication and everything in their life's going well and they're not having cravings, and you take them off, and all of a sudden, they're having severe cravings, they're not going to work, they need to go back on the medicine. So it's really individualized. And it's hard to predict which person is going to, need it for a few months and who's going to need it for a few years. What we do know is it takes at least a year for the brain to really start healing. So I encourage people to typically stay on it for at least about a year, and then see where life is, and how they're feeling, and then start working with that person as an individual. So what can faith leaders do to support medication-assisted treatment? We can encourage, people to engage with their physicians, encourage the congregation to support medication programs, encourage providers in the community to be willing to prescribe medication-assisted treatment. Typically, that would look like Suboxone or naltrexone, which the injectable form is Vivitrol. So encouraging the providers in our community to do that, welcoming individuals that are on medication-assisted treatment into our congregations, into support groups. I've heard of support groups not allowing people on Suboxone or methadone to attend their support group. I think we as leaders can impact that. Really encourage the support groups to be willing to be welcoming, our congregations to be welcoming. I've sent many patients to church looking for community, only for them to come back and tell me that they didn't feel welcomed there, which breaks my heart. We can advocate for increased access to medication-assisted treatment. Sometimes the city council, mayors, they advocate against medication-assisted treatment in their communities. We can, counteract that and try to educate, provide resources, and encourage the reverse of that, to where our communities are advocating for medication-assisted treatment. Before I move on, any questions about anything that we covered so far? And Abby, my screens are not showing me the chat, so I can't even see them on my screens. So if you could read anything from the chat, I'd appreciate it. But any questions up to this point? And you can raise your hand, you can put something in the chat. All right.
Thus far, there's nothing in the chat that we haven't covered.
All right, fantastic. So moving on, I want to talk a little bit about bias, because I think it's an important thing to be mindful of. None of us, are above having bias in our lives, and being willing to be vulnerable enough to accept that fact, I think, is really important, so that we can always be challenging our own thinking and where our beliefs about other people are coming from, because those impact how we treat people, how we talk about people, and how we advocate for change in our communities. Bias can be explicit, meaning that they're very willing to be very open and candid about the fact that they don't like certain people, and this is why. Or it can be implicit, and that's more of what I want to talk about, because I don't think people that have joined us here are going to be standing on explicit bias. But implicit bias is really an unconscious attitude affecting how we think of other people, treat other people, and talk about other people. And there's several types of implicit bias that I think we should be aware of as we're working with not just people with substance use disorder, but really anyone. Confirmation bias. That's basically when we seek out information, research, scriptures that confirm our pre-existing beliefs about something. We find evidence of what we already believe, and we use that evidence only, and we ignore the evidence that may be contrary to something that we believe. It's important to see this because, especially in social media is set up to confirm what we already think and believe through these algorithms. And so we might look at Facebook, Twitter, and think there's all this support for this particular view, but it's only the support within the bubble in which we're operating within. And if we're only looking in certain directions for evidence, we may miss the truth. So it's important to really seek out diverse thinking, diverse thought, diverse resources, and find other things that might really challenge our belief about something so that we can truly think through it and make sure that we're not just exhibiting a bias towards or against something. Anchoring bias is the age-old first impression rules mentality. It's hard to overcome first impressions, but we've got to be aware that our first impressions about something doesn't mean that that's what that something is or that somebody. And so being willing to set aside that first interaction we have with people to really get to know them and who they are. You can't judge a book by its cover. Gender and racial bias. These aren't always conscious. These are sometimes unconscious, and we're not even aware that we're doing them. I've been in meetings where a female leader might say something, and the meeting continues, and then a little bit later, a male leader says the exact same thing, maybe in a little different way, but really the exact same thing. And then all of a sudden, that's a good idea. I don't think the people in the room that I've been involved with are sexist, but they did behave this way. And I do think that there are these systemic biases that we are not always even aware of, but we need to be mindful of them. There's ways that we treat, certain races that are not equal to others, and the same thing applies to gender. And this does branch over into the LGBTQ communities as well, and we need to be aware and mindful of those that we may have biases in that area as well. There's affinity bias, which is basically that we favor individuals that share our background. People that grew up in our town, that graduated from our high school, that go to our church. Whatever that background might be, we just have a natural affinity for those individuals. Again, being aware of that so that we are not treating people differently just because they look like us, talk like us, they're from the same background as us is important. And then attribute bias. This one is kind of important to me. It's it's easy for us to attribute our successes to our personal choices and other people's failures to their personal choices, but excuse our failures as consequences of a situation versus someone else. So just really be aware of that. We give ourselves a lot of grace when we fail, when we fall down, when we mess up. Oftentimes we'll say it was because of a situation. There are reasons why we did not succeed. That doesn't mean that we won't succeed. We're going to try again. But it wasn't because we're bad or there's something wrong with us. Jesus said to love others as ourselves. And part of that, I believe, is to give them the same grace that we would give ourselves. When we look at other people who are failing, not viewing that as a moral failing in their life, that there's something wrong with them, but that maybe it was a result of situations, of circumstances in their life. And if they were given another opportunity in a different way with support, perhaps they would do okay. So that attribute bias, I believe, is important. So how do we combat that? Again, through being mindful, self-reflection. Why do I have these certain beliefs about this group of people or that individual? I've seen this evidence. What's the other evidence that might speak against this that I could seek out? And again, that attribute bias, I think, is really important to be aware of. And the bias really is often implicit. We're not aware of it. It's subconscious, and to really be mindful of that. In medicine, we set up standardized protocols so that we don't treat people, differently just because of who they are. Again, we do need to individualize care, but that initial care that we provide someone often comes through standardized protocols. And we can do something similar, in the community, that anybody that presents with X, Y, and Z, we do this instead of, deciding whether or not somebody is good enough to get care. If they're doing the right things to receive care. Again, in the life of Christ, that when I read the New Testament, I don't see him requiring anything from anyone before he healed them. He just did it. He required things of those that were following him. But the people that were sick and in need, I don't see him ever requiring anything of them before he met their needs. And I've seen churches where they put these requirements on people that they have to do certain things before they're given food, before they're given shelter, before they're given clothing, before they're given help. And I think we can move past that because, again, that's acting on this implicit bias or even explicit bias sometimes. And then seeking out diverse perspectives. It's diversity that really makes us stronger, not weaker. You can think of any sort of foundation. If a foundation is only built on a single pillar, it's going to fall over. The diversity of thought, of backgrounds, broadens that foundation and allows everything that we build on it to be stronger. Any thoughts or comments or questions about that so far? All right, moving along. Really want to challenge you all on what is it to be well? What are the things that we need in our lives to be well? What are the things in the lives of those that we're working with that need to be in place to be well? Well, wellness is not just the absence of illness, disease, or stress. It's really obtaining optimal health from a physical standpoint and a behavioral standpoint. One of the biggest things is identifying the purpose and meaning in someone's life to allow them to have joyful relationships, experience happiness, and to be actively involved in the community through work and play. There's 8 dimensions that are defined by SAMHSA, which is the government, the federal agency that oversees addiction and behavioral health. There's emotional, physical, occupational, intellectual, financial, social, environmental, and spiritual. And if we hit all 8 of these and surround somebody with the care from all 8 angles of this, then we're really providing that individual the opportunity to experience wellness in their life. I think you all can figure out a lot of what goes into each of these dimensions. I have these slides. We're going to provide them. You're welcome to reuse them anytime you want to or refer to them. So I'm going to just skip through those and come to this slide, which this was published by the Surgeon General in 2019. And it looks at 7 vital community factors that foster health, wellness, and prosperity in communities. The Surgeon General issued this report based on decades of sound research. This is evidence-based areas that a community can focus on to make sure that every child born in their community has access to health, wellness, and prosperity. Basic human and safety needs, a thriving natural world that's not toxic. You think of Flint, Michigan, for example, reliable transportation, humane housing, meaningful work, lifelong learning, and the thing that holds it all together is that sense of belonging and civic muscle. So what is that civic muscle, that belonging? It's really focusing on that social aspect, that we are social creatures. We need other people. We need to be a part of something. Some people are experiencing trauma and poverty and inhumane housing and transportation, and being a part of something helps us move beyond that. And having a sense that what's happening in our lives matters. And if we speak up, people are going to do something about it. Being a part of something, we can make change in our community through the civic muscle of us working together. And it brings marginalized people into our congregations, our social circles, and allows them to have access to care that they may not have had otherwise. It allows somebody to feel valued, to feel connected, to feel that their future can be important to other people enough to where we shape and reshape our community. You can look at these 7 vital community factors and break communities down into communities of opportunity or low opportunity communities. And they're really based on the upper part of this slide, which is the Maslow's hierarchy of needs, or the bottom part of this slide, where we're looking at trauma, isolation, neurodevelopment disruption, and such. What happens is people have early disease and early death. And in the United States, we actually have a much lower life expectancy than comparable nations. The developed world has a pretty good life expectancy, and we do too, compared to the undeveloped world or the developing world. But we are, 4 years or more behind the rest of the world. So living in America actually gives you less access to life than living in one of our peer nations. Think about that. In Indianapolis, depending on where you live, you may have 10, 20 years sometimes difference in life expectancy. This slide here, this is there's a trail in Indianapolis that runs about 10 miles. And if you go along that trail, at the north end of that trail, people that live in that area, they live about 83 and a half years. By the time you get 10 miles south on that same trail, life expectancy has dropped down to 69.4. The American dream says that everyone has the same opportunity regardless of their circumstance at birth. But we don't choose where we're born or who we're born to or what circumstance we're born into. But in America, we're supposed to have the same opportunity. You look at a slide like this, and you can see that just based on where you live and where you're born, you may have a difference in your life expectancy. These are the counties in Indiana. Hamilton County is the wealthiest county in the state, so it's not surprising that they have the best life expectancy in the state, 81. Scott County is one of the poorest counties in the state. They have the lowest life expectancy of 69. You're looking at 11 years difference in life expectancy just based on where you're born, where you live in the same state. Zip code should not be a health indicator, but if you're really looking at numbers that a physician would look at, more than blood pressure, more than cholesterol, more than A1C, the thing that tells us how long someone's going to live and how well they're going to live, is their zip code. 1 in every 25 children that are 5 years old in America will not see their 40th birthday. That's different than the rest of the world. By the time you're 75, we're not different than the rest of the world. So once you've reached a certain age, and you're going to probably be fine. But if you grow up in America for some reason, you're not. We don't grow healthy people. The availability of these vital community factors are important, and we should all be advocating for the availability of transportation in every community, of humane housing, of lifelong learning, that our environment is safe. Indiana has one of the most toxic environments in the country, and I've listed some of the stats in the handouts. So whether or not transportation or nutritious food is available in the community is important. But if it's available, is it even accessible to people? If you have to walk 10 miles to the bus stop, even though transportation is available, it's not accessible. Is it able to be utilized? My wife and I have talked about, do people even know how to follow a bus schedule, right? You may have transportation, it may be accessible, but you have to still be able to read the bus schedule and figure out how to get to the place that you're trying to go. And then, is it stable? Even if you have all of these things, if it's not stable, it's not going to really be helpful to the people. In Washington, D.C., we talked about that 10-mile path in Indianapolis. How about this? In Washington, D.C., that 10-mile area, there's a 33-year difference in life expectancy. Again, we don't choose where we're born. This just aligns those community factors with what it is to be well. In Indiana, we have 16.4% of residents living in poverty. If you look at the racial differences, it's kind of stark. More people of color live in poverty than the rest of the population, this is not okay. Transportation is an issue in Marion County, but if you look in rural areas, there's really no public transportation in rural areas. We rank 3rd in the United States for industrial pollution. Housing instability and environmental hazards are a major issue. And again, I list some of the statistics in the slides. So what can we do? What can we do about this? We, I think, can be agents of change in our communities. People in our community trust people of faith. They turn to us in moments when they're unsure of what to do, of when there's societal issues and social issues. They'll turn to us, so we can be agents of change. We can provide mentoring programs, social support programs, social groups, support groups, provide food, housing, assistance, transportation. We can advocate for a clean, healthy environment. Then we can encourage lifelong learning in our community we can offer training programs within our congregations and open it up to the community. We can really advocate for reducing stigma, encourage recovery, and work towards having, some communities don't even have therapy in their communities. We can advocate for behavioral health, for support groups, again, medication-assisted treatment, and such. So I want to break us out into some breakout groups now. I have 5 case studies. I put that in the chat as well. There's a case and then some questions. I'd like each of the groups to discuss the case, go through the questions, and then when we come back, have somebody from your group prepared to kind of give us an update on what you all came up with in the breakout. So we'll see in a little bit.
There are going to be there are going to be numerous breakout rooms. One of us, I'll probably jump into every breakout room to tell you which case study is assigned to your specific breakout room to discuss. Okay, so you'll be divided now.
Cool.
Okay, so there are 5 to 6 people in a room. Is how it ended up being.
Okay. Breakout rooms. So I can just go into these breakout rooms and see how people are doing.
Yes. You see where it says join on
Yeah.
the right? You can just click on join and you'll go into whatever that room.
I see 4 rooms and it looks like there's someone that's unassigned. CFC, Anita Booker.
Mary. Let me send Mary into a room.
I'm going to jump in here and
Okay, no, you're fine.
see how they're doing. And I see where Abby went.
Yeah, Abby was in, I think, room 1. I saw her name pop up. She was in room 1. Now she's in
Oh, I
room
see her.
3.
She's in 3. Okay.
Yeah, so she's probably telling them which case study to take. So she's, yeah.
All right.
So there's a room with only 4 in there if you wanted to join. It's up to you, whichever room you
I'll
want.
give them a couple of minutes and then I'll jump in and just see how they're doing with it. Give them a minute. Things going okay so far?
Yeah, things are going well. I see we have one staff person, center staff is in a breakout room. Yeah, okay. Looks like there's 6 in one room. Not sure about that.
I'll probably bring them back at 1:45.
Okay.
Give us like 10 minutes to kind of talk through things and finish up.
Yeah, I set it for 15 minutes.
Oh.
Back to main session.
All right, we have everybody back. Looks like super. I'm going to go around. I'm going to ask you to for each of the breakout rooms to identify one major point or moments of insight that you all had from the case, and then one major barrier or challenge that you see us facing from the case. And you can kind of give everybody a brief description of what your case was as well. So case number 1, somebody from that group, and I'll read the case. A young mother recently released from treatment struggles with reintegrating into her faith community. Some members see her as a, quote, bad influence, while others want to support her journey. How would the congregation respond? What biases might be at play? So somebody from group 1, do you have any major points of insight, and what challenges do you see?
Hi there, I'm Brittany Phillips, and I was the voluntold person of group 1. So Noemi had the wonderful suggestion of approaching this person, making sure that they know that they are always welcome. She shared some personal experiences about leaving and returning to the church and how that can be so difficult, and just to reinforce that everyone is welcome. Selena had the suggestion of bringing in staff as support. That way it's not just, a discussion happening among the congregation, but that the mother who is returning and on the road of recovery knows that they have the staff support, and that also gives a level of accountability and trust with the folks present that she would see on a regular basis. I mentioned that, living in Indiana, a lot of us do know someone and care about someone who struggles with addiction, which may make us more empathetic, but it also may lead to some implicit biases based on our experiences with someone who struggles, and we may inadvertently transfer that to someone else, even though the situation may be completely different. So I recommended making sure that it's not something that's being debated, but something that we are leaning into our actions. And I love that there are quotes from scripture in here included. Another good one would be John 3:18. We are known by our words and actions. Let us not love with our words, but through acts. So I suggested starting a support group, a forum of people who are struggling with addiction or in the recovery process, so that people know through our acts that everyone is welcome here. Everyone has a seat in this congregation, and that it is a place where people can turn to for support. And of course, Deirdre, I love her suggestion of bringing in a guest speaker to raise awareness and maybe dispel some myths, kind of like what we're doing here today. So
Awesome.
I'm really
Thank
happy
you
with the
very
group.
much.
Well done, guys.
Yeah, that's fantastic. All right, so study group number 2, breakout session 2, a longtime church member and leader secretly struggled with opioid use for years before seeking treatment. Now in recovery, they want to return to leadership, but some congregants question whether they should be allowed to lead again. What do you all think in general of somebody being allowed to lead again who went to treatment and is now in recovery?
I think the question is, are they, a lot of time people say that they are in recovery, but they're actually just clean and they haven't really accepted a lot of things, that cause their addiction, but they're clean and they feel like that they can go on with their lives. We talk about that relapse. So I think one of the fears of the church would probably be, if say you have some educated people on addiction in the congregation, a lot of them probably would have that in their back of their mind. Have you truly worked on your recovery, or are you just clean?
Sure. Scripture says that everyone shouldn't seek to be teachers or
Yeah.
leaders, right? And we're held to a higher standard. As a physician, we have physicians who, end up with an opioid use disorder, go to treatment. And then the question is, do we let them go back to practice or not?
Mm-hmm.
And so we've developed mentor programs and oversight. So people meet on a weekly, monthly basis with a mentor, and then they have urine drug screens, and we make sure that they're doing everything to give them that freedom to be responsible to oversee people's care. So maybe something like that for the church. But let's move on to study group.
Real quick.
Yeah.
Yeah, I think with that too, it's really important that the church also kind of self-reflects as an organization of how did we not support this person in the first place?
Yeah.
For
Yeah.
sure, people can be sneaky and stuff like that. But I think before just putting it on that person and saying like, well, are you doing this? Are you doing this? I think it's important to look at those factors. Like, are we causing stress? Where do we as a church have bad boundaries? Where are we just overlooking things and habits and behaviors and not actually holding people accountable to those? Because those systems also can put our leaders in a bad position.
Yeah.
And so if we're not healthy, but we expect the leader to just on their own be good enough, quote unquote, I think that's a really bad situation.
Sure, self-reflection. So case 3, so we'll have somebody from case 3 mention something that they got out of the discussion and maybe a challenge. This was a father struggling with alcohol use disorder that left his family in financial and emotional distress. The spouse feels abandoned and the children feel ashamed. The church wants to help. Any insight? One preferably, and then a challenge.
Yeah,
I don't see any of my teammates. We didn't
Did they
pick
abandon
somebody,
you?
so I'll just jump in here real quick.
Okay.
So we found, I think that being able to respond to the individual in addiction is something that the church is more ready to do. But the wraparound support for the family and children is an area that still needs growth, and that those are different needs, especially when we're talking about children and just confidentiality and shame in and of itself, and how deep those wounds are. So knowing that there's a lot of systemic things that are happening.
Yeah. And one thing to maybe consider as you go back to work with the congregation is sometimes you have, a situation like this, and then the husband comes back into that situation and kind of blows it up too. So a lot of complex issues to kind of sort through. So the last group was breakout group number 4, and the case is a community leader proposes distributing harm reduction resources like clean syringes or naloxone, Narcan at the church to prevent overdoses. Some members object, believing it's enabling drug use. Others argue that it saves lives. So maybe one insight that you came from the discussion and one challenge that you came from the discussion.
Well, as far as insight, with faith, moral concerns about using harm reduction therapies or tools, that our Lord cares for both body and soul. And so the church can't just say, well, we're here to heal your spirit, but your body's on your own. And Brendia, actually, she works with the recovery ministry at her church. Yeah. And the challenges are that I think we came across from, for people to assume, well, if you're doing this, you're enabling somebody. And Brenda even mentioned that, she's helping people come out of addictions. Some thought, well, I'm just getting addicted to a new substance.
Yeah. I think we'll talk more about harm reduction next week. So if everybody can come back, we'll do that. And I want to thank everybody for joining and taking part of the conversation. These are difficult issues, but they're really important because there's a lot of people being affected. I want to turn it back over to Abby and see if we can wrap things up.